So normally I'd be telling you about all the upcoming presentations for the rest of the year, but this is the last one for this academic year. I don't know whether Andy might put something in the chat about when we're starting up again and who the first speaker might be, but I'll leave that up to him. So now I'd like to introduce Professor Liddy Goyder, or Liddy as she's known to all of us. Liddy's been in ScHARR, I won't say a number of years because I'm not completely sure, but longer than I have, and I hit 20 years this year. And during her time there, or during her time at ScHARR, Liddy's been a real research leader in what is one of the most research active departments at the university. She's had a range of roles, including being the Deputy Dean at one point for quite some time, alongside John Nichol, if anybody remembers when he was Dean of ScHARR. But I'll hand over to you now, Liddy, and I will do the swap over of the slides, so don't worry, I'll sort that out just now. Hold on.
Great, I'll unmute myself, so hopefully everybody can hear me now. And oh yeah, and thanks Claire for the slides. So thanks Claire for introducing me. Yes, I am Liddy. I'm Liddy Goyder, Professor of Public Health in the section of Public Health at ScHARR in Sheffield. And to answer your question about how long I've been here, actually, I've been here, and this amazes me really. It'll be 25 years this September, and essentially I've spent the last 25 years doing the same job. My title's changed during that time, but essentially I have spent a good couple of decades doing applied health research at the interface between public health practice and the work that we do here in the university department. And I was very, very delighted to be invited to run one of these masterclass sessions. I was even more delighted when I discovered that actually I got to negotiate my own topic. And so I'm going to talk, hopefully for not too long, so that there's plenty of time for discussion, about really something that I guess I'm kind of most sort of passionate and keen to share, which is quite a personal experience of the way things have changed around the relationship between public health practice and research. And it was the setting up of the PaRC and what has now become our collective kind of walk in the park, I guess, that has really brought that home to me. What a great opportunity there is now. I am a glass half full person anyway, and I know in public health, the challenges have never been greater. I know that in public health, because we're interested in prevention, essentially our failures are much more evident than our successes. But actually, I think we can often learn from what's gone wrong, and those lessons are important. But sometimes it's, I think, good for all of us to reflect on the things that have worked really well and understand, so why have they worked so well? Why has it seemed sometimes really, really hard, and that we're wading through mud in the last couple of decades, but in the last few years and even more recently, post pandemic, I feel that things have really changed. So it's a personal view. I'll give you my story, but partly I tell that story in the hope that it'll prompt other people to reflect whether it resonates or whether they have their own stories and insights to share. Okay, so I've got a dozen slides to take you through to share the story. I'll start by, again, framing how I see the evidence base around the relationship between practice and research. I'll also give you my take on the policy context and why the things that happened in terms of national policy, both in the research sector and the university world, that have been so important to really facilitate the way that things have changed. The second part of what I want to share is something about what has happened in the Yorkshire and Humber region. This has led to what we've got at the moment, our Yorkshire and Humber PaRC network. I will not be able to avoid using acronyms because, you know, I live in a world where we do work with things called CLAHRCs and LAHRCs, and indeed ARCs and PaRCs. But hopefully when I take you through them, if you're not familiar with the acronyms, I'll be able to shed a bit of light on, you know, what the significance of these particular developments has been. And then the third thing I want to share is, again, a personal reflection on my sense of why the things that you know, we have in terms of the evidence and the policy and what has been developing in the region over a long time, over certainly more than a decade, has led to the situation where I can now really feel that we're making a really significant difference as a collaborative working across practice and research in the region. So during my time working in applied public health research, a lot has been done looking at what the tensions are between the evidence needs of policymakers, of decision makers, of evidence users, and what was being generated by academic departments of public health in terms of research. And I think these things are generally often framed as being barriers, you know, this is why, or this is why it's so difficult. And I guess, you know, so my point at sharing some of these things is to say, actually, you can frame all these things as real opportunities that arise once you get people with a research role and people who are actually, you know, delivering public health and change at the front line together in the room together. And the first of these is the idea that whilst research funding will only fund generalizable research, where you're doing a research study which is going to answer, you know, some fundamental question about a public health question, which isn't necessarily going to be locally relevant, whereas locally what people need is research where they collect and analyse the data relevant to their own population in order to understand the best way to improve health, reduce inequalities. And I guess because I've been doing research all this time, very often working with local partners to evaluate what they do, to look at local data, I guess it's always seemed obvious that there's an awful lot you learn from that which you want to share more widely, that actually there's some generalizable learning that's worth sharing with people in other parts of the country or indeed internationally. And that this is a sort of not a useful distinction sometimes to suggest that these are quite different activities. And of course, during the COVID-19 pandemic, I think the idea that these things weren't related was completely blown apart, because a lot of the work that was going on the ground, understanding how you maximize, you know, screening rates and vaccination rates and, you know, address real ongoing issues, was generating a lot of learning that in terms of sharing it more widely, we now can reflect quite how much we've learned that has been generated through locally relevant research. The other thing often presented as, oh, well, this is why, you know, it doesn't work, is that the research timescale is often years, and certainly randomized trials, it's often, you know, 5 years between someone having the idea for the trial, getting it funded, and actually being able to recruit and collect data and get an answer to the question. Whereas often in terms of policy, people need that evidence, they need it, you know, immediately, they need it yesterday, or they certainly need it in the next few months. But I think the thing that's very creative about this tension is that it's made the research community think quite hard about how they can support that rapid need for evidence. And the example I'd give here is rapid reviews, that the evidence synthesis community has now got, you know, the methods that mean that if a policymaker asks the question and says, you know, what does the research evidence tell us that can help inform our decision? a rapid review can give them that answer really very quickly. Third thing on my list, which again is often presented as an issue, is that the research funders often see the pathway between you do your research and then you write it up, you share it, and then it has an impact on decision making in the real world and has an impact as a linear pathway. But of course, anybody involved in this sort of work is very aware that it's not a linear pathway. There's a really, really fascinating, complex thing that goes on in terms of how these decisions are made and how research might lead to impact. And again, personally, I think we increasingly realize that actually this is quite creative, and actually the fact that you're looking at a complex system means that often there are positive feedback loops in terms of that interaction between the research and the decision making. Finally, again, something which research funders have picked up on as an issue is the fact that public health research, traditionally epidemiology was seen as the discipline that informed public health research. But of course, epidemiology is often a really good way of analysing your problem, but it doesn't necessarily help you to identify the best ways to tackle it, which may be about engineering or architecture or planning. The one that I'm most excited about on this list of examples at the moment is the extent to which in public health we work with lawyers. There are lots of issues around the commercial determinants of health, so gambling, alcohol, smoking, where we can see that there are actions by industry and they are going to want to sell their product. If we can see their products are doing harm, the one lever that I think may be more effective, particularly in the current climate, may well be to get the help of lawyers in understanding that actually there are legal remedies. That's just, again, an example, I guess, just to make the point that if we frame these as positive drivers to doing more effective research, hopefully, we don't see them as barriers. One of the things that we certainly had as a kind of, received wisdom 20 years ago when I was in this field was that one of the problems that we had, and one of the problems that we had particularly in the UK, was a real gap between public health practice and public health research, because as I say, the research was maybe focused on understanding the causes of health problems and inequalities, whereas practice was focused on, well, what are we going to do about it? But of course, sitting in the university, there was also a view maybe that, well, it was all very well looking at the NHS, where there was a culture and evidence-based practice, evidence medicine was very visible, and maybe local government and the world of health in all policies, where people may have been signed up to health as an objective, but there wasn't necessarily a research culture. There wasn't necessarily the same assumption that your policy would actually be based on research evidence. The diagnosis, well, again, this is my personal view, that the diagnosis was obvious, but I don't think you could argue, just looking at the analysis of the money that has been invested in clinical and medical research and the investment that has been made in laboratory research, that nothing like that investment had been made in the research infrastructure and capacity building in the public health world. The other thing which I think was really important was that as soon as I took a job in a university, I was told that both the chances of a contract extension and indeed the chances of promotion depends on grants and papers. And academic productivity was measured in terms of grant income and publication of your work. So in a way, that was a very powerful disincentive not to engage in the sort of work that generally was done on a shoestring and didn't always lead to production of a paper, but might have had a real impact on meeting the evidence needs of people locally. Now, as I kind of said when I kicked off this, I think, when good things happen, rather than just thinking, gosh, we were lucky, it is sometimes, I think, helpful to reflect on what we can learn about what were the key ingredients, what were the things that made things change and made the situation whereby the park could develop and be something that was really productive. And so I'd really draw attention to the fact that, Chris Whitty, as a Chief Scientific Officer, as National Director for the National Institute for Healthcare Research, was a key player. But there were hundreds of people who were talking to Chris Whitty, who were sharing things with him, who were going along to meetings and workshops and identifying what the problem was, what the diagnosis was, what NIHR needed to do to make a difference. And I still have a very vivid memory of Chris Whitty in Doncaster when, before the pandemic, he was touring around local authorities. And you could just see he was listening and people were giving him a consistent message that if you wanted to see us doing the things that were going on in these other fields, then it would need investment. The other thing, which I think we maybe should recognise, is on the university side, which is that the thing that used to be the way that the Higher Education Council for England allocates research money to university changed from something called the research assessment exercise to something called the Research Excellence Framework. And for nearly 10 years, so I think since 2014, as well as looking at things like number of journal articles in high impact journals and so on, and the quality of those academic outputs, the research outputs of universities, which determine their funding from HEFCE, so a really powerful lever, is impact. And by impact, they meant real world impact as measured by case studies where we could actually show the relationship between the research projects and an impact on policy, on populations, on the health and economy of the country. So these were the things that people managed to make happen, which in my view were really important in having the opportunity, which is where we are now, which is major funding for research infrastructure, capacity building grants for local authorities to really invest in developing research culture, doing local research. And I feel that now that it's happening, as I say, it's worth reflecting how we got there in order to ensure that we continue to build on that. So I said I would also say something about what happened locally to put us where we are now in this context. So we were kind of ahead of the game, although it was only a decade ago that public health responsibilities was still a health service, NHS responsibility. At that point, when the Health and Social Care Act transferred most responsibility to local government, we were already working through our local public health colleagues with the local councils in South Yorkshire. And this was something called the South Yorkshire CLAHRC, the South Yorkshire Collaboration for Leadership in Applied Health Research and Care. Now, after 5 years of that, it merged with the West Yorkshire equivalent, and so we had a region-wide CLAHRC, as it was known, and this funded and delivered work with local councils across the region doing public health research and building capacity on a small scale, on a small regional scale, and as part of something which was largely a healthcare partnership, which was actually led by an NHS trust. So it was led still from the NHS, but still in our own small way, we were able to start working with local government. And one of the things that I think we are most proud of from that time was that the establishment of the local authority research links, which was essentially a network of champions for research in every single one of the local councils in the region. And that, I think, is one of the things that really brought home to me how important it is that you have the national champions talking about, Chris Whitty, but also you have the local champions, which was our CLAHRCs. And the only thing that made me really quite unhappy about the things that we were able to do at that stage as a CLAHRC was that it only involved a minority of universities and councils, and inevitably it was the ones that already had an awful lot of funding or were already very engaged in this kind of work. And there was still, as I saw it, huge inequity in the sharing of the learning and the ability for people in the region as a whole to get involved in this. So hence the bringing the story up to date, because at the time that the CLAHRC programme funding ceased, and it was replaced in fact by the CLAHRC replaced by the ARC, an applied research collaboration, which didn't actually have a public health research theme. There was something else going on, which was the Academy of Medical Sciences published a report called Health of the Public 2040. And Health of the Public 2040 had a number of recommendations in related to what should be done to actually drive more effective and useful public health research. But the bit that jumped out off the page when I read Health of the Public 2040 was their recommendation that what was needed were things that they called regional public health research hubs, and which to us kind of sounded like what we had actually been doing with our LAHRCs in the CLAHRC. So given that we already had that network, we proposed at that time to Public Health England, who gave us a lot of support and funded a website, that we would set up something that would not be a CLAHRC or an ARC, but it would be a PaRC, and it would integrate the LAHRC network in a wider network with the universities and the council right across the region. I said that I wouldn't be able to avoid acronyms, and I've listed some acronyms on the last bullet point to highlight the fact that, again, these things don't happen for no reason. Because we'd been working in the CLAHRC, we'd been working with the Clinical Research Network, with the Association of Directors of Public Health, and with our own ScHARR colleagues. Since we set up the PaRC and shared the vision and what we wanted to do, we have been supported by a number of small grants which have enabled us to do some of the specific things that we knew were going to help us to make a difference and share things a lot more widely than we'd been able to do in the CLAHRC, and to really build on that legacy. The regional research hubs have two kind of complementary but twin objectives, and I think it's worth thinking about both how these things are mutually comprehensive, but also the fact that there's no merit in doing, I think, one of these if you don't harness the potential to do them both in tandem. So our vision is very much that this is both about research activity and about knowledge mobilisation. And when we established the PaRC, and we were challenged by the then regional director of public health, Andrew Ferber, to actually, say what we were going to do. It was, we're going to not just do research, we're going to support implementation of research. So, demonstrate that research is being used to inform decision making, not just being done for its own sake, but at the same time to also ensure that we developed the resource and the capacity to actually deliver on research by attracting national funding and collaboration. And we felt quite bullish that, given our track record, we could get our fair share, and maybe even more than our fair share, of the funding that was coming from NIHR for these sorts of activities. And I think, as I say, that's one of the reasons why I think I started to feel so very positive that maybe we had understood what was needed, because it was really making a difference. And the things that we had done as a CLAHRC that we were able to do by setting up the PaRC, information sharing, networking, matchmaking between academics and practitioners and people with concerns about particular policy areas and particular policy priorities, to actually generate the research, providing advice, providing support, ensuring that we put in bids to attract that national funding. The other bit of the jigsaw that we've been able to contribute to is a national network of public health research hubs. So this came about because the Health Foundation gave a grant to the East of England research hub to actually do a piece of work looking at what it was that enabled these research hubs to be established, to operate effectively, and learn from the fact that we were all trying to do the same thing. We had the similar vision, but we're operationalizing it in different ways around the country. And this has led to what we're calling the Public Health Practice Engagement and Research National Network, the FERN network, which means that not only can we network and share practice across the region, but we can do it nationally as well. I'm somebody who, if someone tries to tell me about their ideas at a sort of relatively high theoretical level, I always need examples. So in terms of the sorts of things that we've been involved in, and things particularly, I've listed things that I've been involved in because inevitably those are the ones that I know most about, but I know there are other people here who will have lots of other examples of the sorts of activities that the PaRC can facilitate, which really make a difference on the ground in terms of both research and then getting that research into practice. So I've really enjoyed working with medical students and Sheffield City Council on a project where they looked at the gambling advertising that students were exposed to on their way to and from the campus. I've been involved in a number of master's projects where master's students have worked with councils on reviews, and PhD projects which have developed interventions for reducing sedentary behaviour, sustaining gym membership, where the research project has had a real direct positive kind of impact in the place that's collaborating on it. We looked at the Sheffield local sugar tax. We are currently looking at smoking cessation, drug and alcohol problems. We're doing reviews around warm home and evaluating initiatives. And all these things, it's worth pointing out, they are all properly funded in the sense that both people on the council side and people on the university side are actually, having the full costs of their contribution to this work funded in a way that it never has been, I would have said, before the last few years, and NIHR's big investment in these public health programmes. First is the rapid response team, where councils who have things to be evaluated are paired up with academic teams to do the evaluation, and SPHR, School of Public Health Research, which has a major research programme in collaboration again with councils in a whole range of different areas. We've put a lot of effort into supporting people in local authorities and community organisations to apply for fellowships so that they can get their time, either full-time or part-time, funded at all these different levels. So if you're thinking about doing a PhD, if you want to do a PhD, or even if you've already got a PhD now, there is a scheme you can apply to and have your time funded to develop your own research and develop a career. And then last but very much not least, there is funding for collaborations led by local councils, health determinant research collaborations, where the deal is £5 million for a council over 5 years in order to really change the culture and develop the infrastructure and capacity to be delivering on being a research-led organisation. They've already invested more than 50 million. They've, I think, got at least another 50 million from the Treasury. So I did say I would try and distill some of my kind of reflections on what's made the difference. Why all of a sudden do we feel that we're able to do the things that we've been wrestling with for so long? And I think there were 3 things that, yeah, I just think, we need to remember are important. The finding your champions, we have been, really lucky, but that's something that you can't just assume that people will always think that doing research is important or that evidence-based practice is important. You do need people who within their own organisations, team, departments will be your champions. You then need to actually identify the opportunities where the resources lie. It used to be, quite small little pockets of opportunity. Now there are some really big opportunities, and I think now's the time to seize them. And then I guess the other thing, reflecting on where we started, is that as well as looking for those opportunities, it's well worth thinking about how do you mobilise the resources you've already got. Can you work together to produce evidence reviews to answer those urgent policy priority questions? Can you use resources, students, local evaluations to get some local research underway? The final thing that I wanted to reflect on before kind of opening the floor up is what also, I guess, is making me feel positive, which is the fact that we are now at a point where we can deliver and demonstrate that impact that is so important in terms of both knowing that we're doing something worthwhile, but also demonstrating to the wider world and to those people we're dependent on for the resources how worthwhile it is. And so again, I've just suggested 3 areas where people can look and think, oh yes, what have we done? Where are there new posts or new programs? So locally, as I say, we've been successful with fellowships, with funding for embedded researchers based in councils. The First Steps and Next Steps programs are programs that support local authority staff who want to get into research. There's also some examples now that I can share, and I think other people will have others, of where the research that we've done with our local partners has had a real impact on commissioning decisions, where we may have been involved in evaluating a really innovative pilot programme. A Sheffield one was the Housing Plus programme, and as a result of that, it meant that we could inform how that programme was recommissioned. lastly, of course, I think it is really important when you can actually demonstrate the impact of the work on local communities, where you can actually show that practice has changed, where the reach of services that maybe weren't reaching some of the people who could benefit and have made a difference, where you've made a difference to local green spaces and things that affect the whole population. Like air pollution is an obvious one, I guess, at the moment. So I did say that I would try not to talk for too long, because I think I give you my take on where we are and why, at least in Yorkshire and Humber, we think we understand what the recipe is. That other people, I'm sure, will have other ideas. But this is just really my take home in terms of this is what we need to carry on doing. Find our champions, identify our opportunities, mobilize all our resources, and document and celebrate the impact that we're having.